Hello everybody, welcome to our next series of our IPRS Health webinars. We are going to talk today on the subject of painful knees. Today we've got my colleague Ashley James on and myself, so I'm going to give a quick intro into both of us just so you know who we are. Ashley, do you want to give a quick intro into yourself?
Yeah, so my name's Ashley James. I'm currently one of the clinical leads of occupational health physio along with Paul for IPRS. My background is in occupational health for the last couple of years, and before that I was in professional sport with Welsh Rugby, and I'm currently doing my PhD in occupational health.
Perfect, and I'm quite similar. So I'm one of the clinical leads for IPRS Health as well, and my background's working in combination of NHS and private practice, predominantly in musculoskeletal. Done a bit of sports background and quite a lot of background into working in exercise rehab. So what we're going to do is we're going to just give you a quick preview of what we're going to have a chat about. So the webinar should be about 30 minutes, no longer, and then we'll open out to any questions and answers that you might have at the end as well, and we'll give you some resources to help you. So, okay, so I'm just putting this up. If you are on Twitter, I don't know if you're allowed to be on Twitter at work, maybe not, but if you are on Twitter, if you could go on Twitter maybe just to give us some feedback. So we appreciate any feedback about the webinar that you're viewing today. The Twitter name is at IPRS Health, and if you can give us any feedback that you can on the webinar, it would be absolutely well appreciated, and you can just put in hashtag IPRS Health webinars alongside your feedback. We're going to start off, and we have this on Twitter, so if you do go on Twitter, it will be, you can answer this poll, and we'll give the results of the poll at the end. So anybody on Twitter, get onto it and have a look at this poll, and let's just get our brains thinking around it a little bit. So Ash, do you want to run through that here?
Yeah. So the question is pretty simple. So it's, in your experience, what have you found best works or has worked for your knee pain in the past? So ultrasound, acupuncture, massage, or I don't think stretching's on there because we didn't have enough options, so it's just strengthening. But if you want to go over to Twitter as we're talking now, you can answer that poll if you get a chance. If you're not allowed to work, don't do it.
Yeah, don't blame us if you're not allowed. Okay, so what we're going to have a little chat about today is we'll have a quick chat about pain, so different types of causes of knee pain. Although knees are kind of one single area of the body, there are quite a large range of different causes of knee pain, so we'll stick to the most common causes in musculoskeletal knee pain. We're going to have a chat about risk factors for knee pain, what we can do to treat and prevent knee pain. We'll have a quick chat about what's a common question about scans and knee pain. We're going to provide some resources and examples of exercise programs for knees, and also in relation to work, does your work cause knee pain, and what can we do to help that knee pain? So in knee pain, there can be various different types of causes of knee pain. We're going to stick primarily to what we call musculoskeletal knee pain. So that's any knee pain that's caused by muscles, bones, joints, soft tissue like ligaments, and so forth. And the most common causes of musculoskeletal knee pain are these ones you can see on the side of the presentation. So we've got osteoarthritis, patellar tendon pain, patellofemoral pain, you've got knee ligament injuries, and you've got knee meniscus injuries. I'm going to have a quick chat on the first two ones. So we're going to start off on osteoarthritis. And I think most of us would have heard of osteoarthritis before, some good, some bad. So I'm going to quickly run through the basics of osteoarthritis. It is the most common form of joint disease, and it's the most common, and certainly from my experience, it's the most common referrals that I would get in for knee pain. If we know osteoarthritis basically is what affects the cartilage in the knee joints. So basically we've got cartilage at the end of the bones that create a joint. The cartilage is a structure that helps prevent friction of a joint, that helps the joint move, protects the ends of the bones. And basically osteoarthritis is where it has affected that cartilage, but it's not as simple as that actually. We used to think it was just affected the cartilage, but we know it actually has affected the cartilage and the surrounding soft tissue around that area, such as the ligaments around the cartilage and the muscles around that cartilage. There is a lot of research, and continues to be a lot more research in osteoarthritis of the knee, and a part of that research is what are the risk factors. So it's quite important for us to know what the risk factors are, because it can help us manage that knee pain if we have it, or it can help us prevent that knee pain if we understand the risk factors. So one of the first few ones are probably the most highest level of what we call clinical evidence that we have out there. So it's the best evidence we have, and we know first thing is increased body mass. So increased body mass, I mean anything that is anybody who's overweight or what we classify as obese. There's a much higher risk of osteoarthritis in the knee in this category. Now, this, if you ever had your BMI taken with your body mass index, this would relate to, if you think 18 to 25, the number 18 to 25 is normal BMI. Anything above 25 is classified as overweight, and higher than that into obese, obviously. So there is a bit of some myths around increased body mass and knee pain, that it's just the increased load on the knee that increases the pressure on the knee that causes it. That's not. It's not really as simple as that. It is one of the factors that cause it to be a risk factor. Another factor to excess body weight is that what happens is when we've more fatty tissue in the body, it increases or changes the metabolism of the body, and with more fatty tissue, I'm not going to go too in depth here, but with more fatty tissue, you get more of an inflammatory environment, we call it, and basically that will just predispose us a little bit more to osteoarthritic changes in the knee. Previous knee pain is also very highly related to osteoarthritis of the knee. So we know people who have previous injuries, such as ACL injuries, you might have heard of before, as a ligament injury, previous surgeries, and we know there's a higher rate of osteoarthritis, and people who have arthroscopies and so forth are more predisposed to having osteoarthritis. Age, unfortunately, is another one. So between the age of 50 to 75, there's a higher incidence of osteoarthritis. There's a big debate over this. Is it the actual age that's the problem, or is it the factors around getting old? So the argument is that actually it's not the age that's causing the problem, it's the factors such as we become less active as we get older, there's a tendency to increase in weight as we get older, so things like that we've got to think about with age. Unfortunately, there is a higher incidence of osteoarthritis in females, and some things we can't really change, they're not modifiable. So you would think of anatomical changes, different changes in the size of the pelvis and angles of the knee. There are hormonal differences, particularly in postmenopausal women. If there's a deficiency in the hormone estrogen, there's a higher incidence of getting knee osteoarthritis. So that's why we know women and postmenopausal women who have estrogen replacement therapy have a reduced risk of developing osteoarthritis. Heavy manual labour is another one, which is a question we get asked quite a lot. And actually, the heavy manual labour, I'm going to emphasise heavy manual labour. It's quite a difference between just general manual labour. So it's a bit vague, the evidence, but the general recommendation is if people have to lift in excess of 25 kilograms on a very frequent basis. So that's quite a lot of lifting, heavy lifting, and quite a lot as well, a frequent basis. Prolonged standing is another one that is a potential risk factor, and again, the prolonged standing is quite significant. We classify it as 1 hour of continuous standing for a combined total of 4 hours per day. So it is a lot of standing with minimal recovery in between. Prolonged kneeling is an obvious one, I suppose. So kneeling for long periods of time in your job, for example, and the general guidelines is if you have to kneel for more than 2 hours per day, you're putting yourself at a higher risk. And finally, there is quad weakness, and we know that people who have reduced quadricep strength are probably more likely to have more effect on their own physical function, and if we increase quadricep strength, we're going to decrease pain and osteoarthritis, so that's an important one. The symptoms, if you haven't have osteoarthritis and if you're interested, or if you have it, you'll recognize some of these. It's that pain. It's pain that worsens throughout the day, or it gets worse at the end of the day, or some people will say it's really bad in the morning. First thing when they get up and they go to stand and move around is quite sore. Usually we say it's pain that gets worse after a period of inactivity, and then you go to weight bear into the knee. You will find stiffness is always a problem, or not always, a lot of times is a problem. So stiffness, it's tight, it's sore, it bends. Swelling, you'll see that can get red and a bit thicker around there sometimes. And another term we call is crepitus. Crepitus I describe as like a grinding noise or a creaking noise or crunching noise, and it's in osteoarthritis. It's more related to these type of noises that are correlated with pain. They're associated with pain as well. I kind of just want to let people know that clicking in the knee is very common, and it's normal for the knee. So if you get clicking in the knee from you sit down or you stand up and there's no pain with it, don't worry about that. That's not a sign of osteoarthritis by any means. It's this very horrible grinding and creaking noise, and it's always associated with pain. I'm going to run through patellofemoral, or sorry, it's not patellofemoral. I'm going to run through patellar tendon pain as well. So this one is located more to the front of the knee. So the patella tendon is basically a tendon that's just below the kneecap and attached into the lower leg, and you'll feel it very localized within that area. The risk factors for patella tendon pain, unfortunately, again, is there is a high risk factors for females, and it's going back into the same hormonal changes with estrogen deficiency and a few anatomical changes as well. The other thing is areas of training. So we can identify patella tendon pain is very much a mechanical type of pain. So you can see, you can relate it to associate with a lot of certain movements. So running and jumping are very, there's a high correlation between a lot of running and jumping in patella pain. Sudden change in activity, so people who say they've done something new, they've changed, being work or at home, is also another risk factor, which I'm going to have a little bit chat about later. But sudden change can be anything. It can be changing into a new exercise program. It can be, doing all your DIY over the weekends, and it's that change in load that can exceed what the tendon's capable of and just cause that irritation. Flexibility in the lower limb, so that's another one. There's a bit of evidence behind that. We know people who have reduced flexibility in the hamstrings, which is the muscle in the back of the thigh, and reduced flexibility in the ankle. There is a higher instance of osteoarthritis in those, and it's probably more related to that restriction of movement is loading that tendon that little bit more. It's almost pushing to the tendon to work harder. And then you've also got your quad strength, so same as osteoarthritis, reduced quad strength. There definitely is a bit of a correlation in terms of risk factors there. The symptoms are slightly different to what you would find in osteoarthritis, in tendon pain at the knee. So you would get pain that is commonly felt with, as I said, mechanical pain that's felt with specific movements. So running and jumping is what we see quite commonly. The pain usually worsens or is caused by a change in loads, which can be at work or can be when you're playing sport, for example. So, like, I'll give you an example. Yesterday, a patient I had who told me that they said nothing had changed. They hadn't changed anything in their activity or the loads. And when I questioned a bit further, they'd been on holidays for 3 weeks, absolutely relaxing as they should on holidays, lying down, very minimal activity, a bit of walking. However, they're in quite an active job role where they have to walk quite a lot and stand quite a lot and lift quite a lot. So when they went back to work, they noticed the pain developed. And that's a change in load. That's from going from not doing very much activity to going straight back into full hours into work, and being quite active in work. So that it can be very subtle little things like that. And the pain tends to be worse in the morning. Similar to osteoarthritis, it tends to be worse in the morning. Some people will say the pain tends to be worse after they do certain activities. So if they went for a run, it could be very sore after. Or another common pattern is pain is, for example, if you're running, you'll feel the pain usually at the start, and as you warm up, the pain eases off, and then the pain gets sore again after the activity. So they're more kind of your common presentations for that tendon pain. Ash, I'll leave this one to you.
Yeah, so over to me. So this is slightly different to the one before. So patella tendon pain, as Paul said, is the tendon itself, which is just below the kneecap. And patellofemoral pain is knee that's generally around the front of the knee, so we'd call it anterior knee pain, but it's not as localized as the patella tendon pain. And it can be caused by a number of things. But one of the things is the kneecap just doesn't sit quite right in that groove that's in the top of your knee, and that can cause a little bit of pain and discomfort. And it differs in a few ways. So again, unfortunately, females has a higher risk. Reduced quad strength is there again. There's also a really strong link in the evidence actually to anxiety, depression, fear of movement, and your beliefs around what causes your pain. You know, those things, if those things are worse, then your knee pain tends to be exacerbated a bit. The volume on the pain is turned up a little bit. BMI, again, as Paul said, is a risk. Smoking, excess movement of the patella, and training volume again, as in the patella tendon pain. So the main difference with this is tends to be where the pain is felt. I'm going to click it on one, Paul.
Sorry, it's just frozen 1 second. There you go.
Oh, there we go. And symptoms, so pain with activity or after it tends to be really common. Pain when you're going upstairs, pain with prolonged sitting, and pain with kneeling or squatting. So as you can see, there's quite a bit of overlap with some of these things, but there are subtle differences between what type of knee pain that you have, and you know, we just thought it was important to help you try and understand those little differences, because it does change the management slightly. I'm going to click on to the next one. So knee ligament injuries are a little bit less common and a little bit more obvious. So they usually occur from a trauma, as it says there. So whether that's you've fallen, or whether you play a bit of sport at the weekends, or whether you run, or it tends to be because you've done something acutely and suddenly. And depending on that ligament will depend on whether or not you need to get any onward care for surgery and things like that. And the last one on there is knee meniscus injuries. So the meniscus is the cartilage in between the two bones of your knee. So the bottom of your leg and your top of your leg, there's ligaments there that kind of add to the stability, and there's meniscus, which is like a spongy cushion in between that helps absorb shock and things like that. Now the onset of these can be suddenly with a trauma or gradually. The risk factors are there, so sports participation, any trauma to the knee can cause a meniscus injury. BMI again, smoking, and age 50 plus is a risk factor. So the symptoms with this and how it's different to the first three is the pain tends to feel like it's inside the knee. It's more common on the inside of the knee than the outside, and you get pain when you're kneeling or squatting. Now, the implications for this are, if your knee pain has come on gradually, then what the research has found is it's actually better to rehab it, see your physio, and go the conservative route. If you get surgery on it, the outcomes are no better. So it's actually better just to do physio and rehab and strengthening, which is why that's an important point to make.
Okay, so we're going to run through just knee pain management. So how you can manage this knee pain to help obviously reduce if you are in pain, so help reduce the pain and prevent it from deteriorating as such. So I'm going to quickly run through the first one, which is exercise. So obviously, as physiotherapists, we're a bit biased to exercise. We know it's really good for us. We know the benefits of it. So there is definitely, in terms of osteoarthritis at the knee and other, such as patella tendon and the other cause of knee pain, the evidence, the medical evidence that we have for exercise is probably the best evidence that we have. We can certainly prove that exercise has a massive and profound effect on a lot of these types of knee pain. And it does need a rock science to think of it. So if we kind of go back to what we discussed with the risk factors, so, you know, overweight or obese, quadricep, the muscle front of the thigh, quadricep weakness, lack of flexibility, training volume, and even low mood, anxiety, things like that, they're all very highly influenced by exercise, so they can modify those risk factors, so it's so important. We do recommend for knee pain that you do get a bespoke exercise program, so you know, get into your physiotherapist if you're looking to have an IPRS physiotherapy referral system, book in with us. If you're in current pain particularly, we'd recommend that. And there is a lot of emphasis for exercise, and a lot of research show that strengthening the quads, that muscle in the front of the thigh, is really important for reducing pain and improving function in a lot of these painful knees as such. So exercises like squats and lunges and step-ups, those type of exercises are fantastic for this type of pain. I'm going to just quickly say and keep it simple. With exercise, we're not telling you have to go to a gym or you have to do an exercise that's really boring and that you hate. I would always say do something that you enjoy to do. Okay, so do an exercise that you enjoy to do, that doesn't make it too sore for you, that you can challenge yourself with, certainly, but it has to be fun. You have to enjoy doing it or you won't keep doing it. The other one is change and load. So we can break this into two categories. Change and load, we'd say you can change load in terms of exercise or what we do as our hobbies, and we can change load of what we do at work as well. So examples for change and load would be considering to, in the exercise or in your hobbies or sports, would be reducing the intensity. Consider reducing the intensity a little bit. So usually if you're in some sort of knee pain, we would say, well, modify that load a little bit. So maybe drop it down by 10 to 15%. For example, if you run for a half an hour, try run for 20 minutes or run at a slightly slower pace or choose a flatter route just to reduce that load and then monitor it and see how it responds to it. Modify any exercises that cause pain, which sounds common sense, but obviously some people prefer to go through the pain. So if you do an exercise and it really irritates the knee, it's causing a lot of pain, it's sore afterwards, it's not making it feel better, don't do it. Change it. reduce the movements, change the amount of reps that you do, modify it so it's a nice tolerable load. It's not too much pain. It's alright if it's a small bit of pain, it's absolutely fine, but it's not extremely uncomfortable. An example I give of that is we get a lot of people with knee pain such as this. They go and do a full-on sit to stand or a squat, and it's very sore when they get down into the lower phase of the movement, and we modify it by doing what we call a quarter squat, so just going down half that way, or doing a wall squat where they take a bit more load off the knee. So simple little changes. We also say to also just consider recovery time. So a lot of us will, we'll do our weekend warriors where we're doing sports on the weekend, and then we're in the gym, or we're doing running, or we're just really busy during the week, and we're exercising quite a lot, and we're not allowing ourselves that recovery period. And you've got to remember that when you're loading the knee, when you're exercising the knee, you are creating a form of micro damage to the muscles as such, and then what happens is the muscles respond in the period of recovery, and they get stronger and better. So giving yourself that recovery period to allow yourself to adapt to the exercise. In terms of workload, what I'd recommend is again going back to those risk factors is really important. So we know kneeling, prolonged kneeling, heavy lifting, prolonged squatting, they are all risk factors for knee pain. So modifying those, change them around. We recommend, it doesn't mean you have to restrict yourself in work, but you can also be a bit clever by rotating your tasks around a little bit more. Ask for help if you have a colleague, a buddy, and he's going to ask for help with certain heavy lifts, for example, and use equipment. If you're doing heavy lifting or anything, use hoists or whatever you can to assist your trolleys, etc. You've got other techniques as well in terms of reducing load. So, if you're unsure if there's any ergonomic issues, for example, that you can request a workplace assessment, for example, where we can come in and do a risk analysis and see how we can change your work environments to reduce that risk. And then I'm gonna quickly just run through psychosocial factors, and then Ashley's gonna go through the rest. So psychosocial factors means other factors apart from the physical side of things. So actually, most people think knee osteoarthritis is simple. It's to do with the knee joints, the wear and tear of the knee joints, the physical aspects, and that's it. And unfortunately, it's not that easy. It's quite complex as well. So there's loads of other factors that contribute to that pain. I'll keep it simple as I can. So there's things like fear of movement. So if you've got pain in your knee, particularly if you had pain for quite a while, you're going to begin to become fearful of doing certain movements that create that pain. So bending the knee, kneeling down, things like that. So that can begin to create what we call a vicious cycle, where you start to get the knee even stiffer and weaker, and then it creates more pain. So don't be fearful of movement, or get that advice from your specialist physio. People can be fearful that if they do activities that it's going to make it worse in the future, so they become fearful of movements because they're going to make the knee pain much worse in the future. It's not going to happen if you get the right advice. Other things like low moods, depression, anxiety, they're all factors which will sensitize pain. So if you have pain for a while, and we all go through periods of low mood, or if we're in depression, or we're anxious, and it's particularly anxiety, depression over a longer period of time, that's going to sensitize the pain that you already have and make it feel a little bit worse. An understanding of the pain, education of what's causing that pain is so important. And the more you understand, the better you can manage it, and you'll find the pain reduces. And there's some great techniques out there. For example, within IPRS Health here, we've got techniques such as cognitive behavioural therapy, which is absolutely fantastic for people with long-term pain. Functional restoration programs we offer, which combines a lot of the psychosocial education with the physical exercise. So these are fantastic services that we can use as well to help, particularly if you've got the longer-term pain.
Thanks, Paul. Yeah, so I'm just going to talk about all the green ones, because the reason they're different colours is the purple ones are the ones that are the bedrock. They're the ones that we should be doing, and they're the ones that if you don't do, your pain is unlikely to get any better. So if we're not modifying the load, we're not doing any exercise, and we're not addressing any psychosocial factors that may be present, it's very unlikely that your pain will change, actually. And what people tend to do is go straight for these green treatments. So hands-on treatment, so your massage and your manual therapy, ultrasound, maybe injections, some taping, some acupuncture. These are all great, and there's some evidence to suggest that they can reduce pain, but for a very short period of time. So they can be beneficial at reducing pain. There's no doubt about that. But if they're just done on their own, it's likely over a long period of time that your pain is not it won't change. So what we need to do is, the green ones are okay to deliver as long as they're underpinned and managed by the purple bubbles. So they're the bedrock, and then the green ones are things that we can add on at the end to give you some further pain relief. But we're looking here to get some long-term pain relief of this knee pain. Do you want to move it on, Paul?
So, okay.
Okay, so this is just a brief thing about scans, and this, this is pertinent to the patella tendon issue, and actually scans in general. So I thought it would be really important to mention. So wear and tear on a scan is perfectly normal, and this is true of tendons. This is true of lower backs. So whether it's an ultrasound of a tendon, whether it's an MRI scan of the back, the link and correlation between structural damage and pain is actually very, very weak. Pain doesn't always equal damage, and damage doesn't always equal pain. So just because they scan something and it looks what you would call abnormal, doesn't mean that's the cause of the pain necessarily. So they can be useful, and they can help in the right circumstances, but the message behind this is just to generate that little bit of interest that if you have a scan, don't hang your hat on it. It's not the be-all and end-all. Scans can help us in some circumstances, but in other ways, they can kind of fuel that fear of movement, the negative beliefs around pain. And what we want to do is really move away from that, because the scans don't give us all the information. They only give us some of the information. So what I liken it to is, imagine sending your car to the Ferrari Formula One team. It's a really fine tooth comb of a look, and they'll probably find a few things wrong with your car, but it doesn't mean that the car doesn't run perfectly fine. So it's just to be mindful of that any kind of scan is a real in-depth look at detail, but sometimes we don't need everything to look perfect on that scan for us to function perfectly well.
Perfect. So just moving on, I'm going to show you an example here of an exercise program that we use for knee health or knee strengthening exercise program. I'm just going to clarify, this exercise program isn't specifically for specific knee conditions. So if you have a pre-existing knee problem or you're in knee pain, we do recommend that you get clearance from your physiotherapist to do this exercise program, or even through your GP if it's easier. And obviously, if you do it through a physiotherapist, we can go through these exercises and make sure that we're doing them right and help you in developing goals and progressing. If you don't have too much pain and you're confident with your exercise, obviously you can try this exercise program. It's quite simple, and basically it's just a combination of mobility exercises and a few strengthening exercises and some stretching exercises. So kind of getting back into those risk factors. We know quad weakness is one thing we got to work on. We know flexibility is another thing we've got to work on, and this program incorporates all those factors. I'm not going to go through them individually now because we'll be here all day, but what we do is we have a fantastic app called the IPRS Health app, and we can provide these exercises in a video format that gives a full description of each exercise, and there's a load of other helpful resources on that app as well, and we've just recently won the Rehab Awards for this app. So if you are interested in getting this exercise program, I'll put our email address at the end of this webinar, and you can just send us an email. Just if you can let us know that you want a copy of the exercise program, and also just let us know your year of birth if you can. We just need to put that in for the app. So basically, you've got a stretching routine, you've got some squats where we're bending down, bending the knees. Again, you work to whatever you feel is a tolerable load. It's not too uncomfortable for you to do. We've got lunges, moving out diagonally. We've got bridges where we're lifting the bum up and down. We've got an exercise called a clamshell where we're working the outside of the hip region and the glutes region. And then we've got our two stretches, stretching the quads and stretching the hamstrings. Quite simple exercises. Reps and sets are guidelines for you there as well. But again, if you have an opportunity to see a physio to go through this, I highly recommend that first. So I'm going to quickly have a chat about knee pain that we get at work. So is work causing knee pain? What can we do to change that? Is there anything we can do to change that? One thing that we know is complete rest is definitely not the best way to manage symptoms. So if we completely rest, Like I give you the example, the person going on holidays and then going back into to work, then you're more likely possibly to continue with the pain or to weaken the knee as such. So what we recommend is activity modification. So changing the activities to suit you. So it's individual to each person. So we say identify the tasks or the activities that aggravate your symptoms. So is it bending the knees? Is it going to kneel down? Is it reaching into awkward spaces, lunging into awkward spaces? Those type of movements. What's aggravating it? How can you change it then? So basically, can these tasks be changed or can they be avoided just for a small period of time? So ask yourself that question first. Can somebody else help out? Can you do it a different way? If yes, then you got to limit or avoid that specific task or activity for a period of time, just until your symptoms settle down. So you don't have to stop or change this completely. You just need to change over a shorter period of time. If you can't, then consider whether you can modify how you perform your tasks in order to reduce your aggravation. So examples for this would be, we identify the aggravating position and then we change it. So do we need to make amendments to our work duties? Do we need to get formal restrictions from our employer just on a short-term basis just to assist you in recovering from this problem? Maybe micro breaks, so taking quick breaks. So micro breaks could be sitting down for 10 seconds every 10 minutes or so if you're in a standing position job. If you're in an office-based job, getting up and walking around every 10 to 15 minutes. Variability of movement is also really important as well. So if you're in a job that's repetitive, so if you're in a job that where you have to, stand or step or move in a very constant, static, repetitive way, can you just change that movement pattern a little bit more? The more we vary the movements, the more the body responds to that and the less likely to irritate us. And job rotation is a really important one. Again, in jobs possibly where you are in a job where you're doing a lot of repetition. So if you do one particular job, can you change it and rotate it with another job that has a different type of movement? And again, that's that variability of movement. So just things to consider in regards to work. Again, ask your employer for help on this. They're usually really open with helping in this type of things. If you have an OC Health department, again, ask OC Health or the physio on site if you have a physio. And everybody together can help manage that and improve it for you.
Okay, let me check the poll results. So let me just refresh it to see what we're getting. Oh, exactly how we'd hoped. So 0% for ultrasound, 14% for acupuncture, 14% for massage, and 72% strengthening. So hopefully some of those people voted after we gave them the information, but it's good that people generally knew that strengthening was the way to go. So hopefully we've given you some additional information on top of that have helped reinforce those beliefs that strengthening is really important and rehab is really important.
Great.
So just in summary, I just wanted to put a little bit of a pyramid together to reiterate the points that we've made. So at the bottom of that pyramid are those three purple bubbles: load modification, exercise, stress management, and education around pain and around the knee. That they're really important. They're the bedrock. The next level up is to seek healthcare advice early on for an intervention. So like Paul said, if you've got OC Health, if you've got a physio, early intervention is key. We know that if you see a physio soon rather than later, you're more likely to stay in work and you tend to have less pain, lower pain scores. The next thing in that is to look at solutions to potential risk factors in work. So as Paul said, job rotation, modifying tasks, doing things in a little bit different way, movement variability, micro breaks, adding all those things in. And then if we move up, there's the manual therapy and massage for pain. So once we've got all the underpinning things in place, we know we can move on to these short-term pain relievers because we know we've got the long-term plans in place. So there's your manual therapy there. And then right at the top, the ones with the least amount of evidence and are shown to be the least effective, splints, strapping, acupuncture, and electrotherapy. So, like I said, those things are okay to get as long as everything else underpinning it is in place and ready to go.
So as I said earlier on, if you want the exercise program, everybody who's on the webinar now, we can send them out a free access to this exercise program and access to the IPRS Health app. So you just need to email probably just email both of us, actually be easier. So email paul.scallon@iprsgroup.com and ashley.james@iprsgroup.com, and one of us will set it up for you. We will send you an email link to the app where you can download the app and you can get access to that program that we'd mentioned earlier on the webinar. A fantastic app. You'll also get access to another resource that we have called myIPRSHealth.com. And if you want any more education, this is a brilliant website. You can click on the link on the app. It'll bring you to the website, and it'll give you a range of resources and education about different musculoskeletal injuries and how you can help self-manage those injuries. It'll give you access to our blogs and previous webinars and so forth as well. So it's a brilliant website to utilize. This is our website. If you go into our website, if you want more education, we have a news and blog section. So we do quite a lot of blogs for patients. So for example, we have a work and shoulder blog, so you can access them. We will have access to our previous webinars on this as well, so by all means go onto the website as well. And that's pretty much it. We wrapped it up. Actually, we've done well. We've actually kind of just kept on time. It's good. So yeah. So what we'll do is we're going to leave it open for about 5 minutes. There is a tab. If you look on your right-hand side of your screen, you'll see a tab or a toolbar, and it will have a section for questions where you can type in questions. We won't open it out to people speaking because with the high volume of people we have on the call, it'll be very difficult to hear. So if you want to type in any questions that you have in regards to this webinar, in regards to general knee pain, go for it, and we can try answer as best we can. We can't, whilst you're typing, we can't answer specific questions about your own specific problem. Obviously that would need to be fully assessed, but if you've got general knee queries or you're looking for any advice, type in now, type in a question. We'll leave it open for a few minutes, and then hopefully we can get some questions we can answer. Okay, so we don't have anything yet. We'll just keep on for a little bit longer. So again, if you are lucky enough to have a physiotherapy service like IPRS Health on site, or if you have part of our clinical network, and you have knee pain and you're unsure, as we said, early intervention is key. So see if you can get a referral. Ask your manager. And again, looking into any of our other services like our CBT, our cognitive behavioural therapy services There's a new service we brought in, which is fantastic. You can ask us for any advice on that. And we've also got other services like Functional Restoration Program, and we've got our Workplace Services program as well. So if you want to ask any queries in regards to the services we provide, please by all means email us. Okay, so we have one question in. Okay, so the question is, what about desk workers? So is there any top tips for reducing pain when working at the desk? So one of my recommendations for that is going back into what we said about load modification. So really working on that variability of movements. So people who are working at desks tend to be seated for long periods of time. And we know particularly in things, especially like osteoarthritis and the tendon pain, prolonged periods of inactivity followed by movement can irritate those problems. So getting up, moving around, even in the chair if you can't get up, bending and straightening the knee, keeping that knee as active as you can will make a massive difference to that knee pain. You'll also, going back into the exercise, having a look at what your activity you're doing. Is there anything we can change? Do we need to do more activity? Do we need to do an exercise program, or do we need to modify the activity? Is really important as well. Ashley, have you any more on that?
No, I think that's covered that really well. I'll move on to the next question. So we've got a second question here. So for knee strengthening, is light squatting the key? I.e., don't try to progressively squat heavier. It's an interesting one actually, because a lot of people have the conception that squatting is really bad for the knee. But the key word that you've used there is progressively. So what I wouldn't advocate is going from not squatting at all to squatting really heavy. You're right there. So I wouldn't say, if you haven't done any squatting now, I wouldn't say don't go start squatting your body weight tomorrow in the gym. Light body weight squatting is definitely a good starting point if it's something that you're new to. But if you progress slowly and carefully, and you progressively increase the weight over a long period of time, there's no evidence to suggest that that's detrimental to your knees in the long run. In fact, it's probably better for your knee health to continually strengthen your knees over a long period of time. So it depends by what you mean by heavy, but I would focus on the word progressively. So as long as you do anything progressively, you know, you tend to be in a pretty good space and reduce your risk of injury quite significantly if you do it progressively over time. For me, there's no movements that are off limit. There's no movements that are inherently dangerous. There's no exercise that's inherently dangerous. It's how you approach it, and exercise shouldn't worry us in the slightest. Exercise is a great thing for us to be doing, so don't let the fact that you know, you see people squatting heavy in the gym put you off. As long as you progress up to it, you're okay.
Good stuff. We have another question in from Julie, a good question as well. So the question is, any tips for dealing with the cold and wet weather, which makes my knees creaky? So one of the reasons we have the webinar at this time of the year is because we do find there is an increased amount of people coming in with sore knees when the weather gets colder. There certainly is, we get a higher instance of it. So it's certainly a very good question. We can change that by movement. If we keep active and vary our movements frequently, we're going to generate that internal heat in the knee. So not only will it lubricate the knee, but it'll also, you know, it'll warm up the knee and make it feel better. There are various different ways to keep the area warm. Such some people will say just will help with the pain. So, you know, if you want to wear your thermals underneath your trousers or anything like that, you know, to keep the knee warm, there's no harm in doing that. It'll reduce the symptoms, and it probably will allow you just to move the knee a little bit more as well. So really trying to keep that knee moving frequently is important. Applying heat to the knee is absolutely, there's no problems in applying heat to the knee if you feel that it's very cold and creaky. I'm trying to think of anything else. Ashley, anything else you've got for that?
Well, I think the important thing with that question is not to worry about it too much, just because you know, it may feel a little bit maybe creakier in the winter. That's not necessarily a bad thing. You know, the cold and the wet weather does not increase the damage within your knee. So even though it may feel a little bit more painful, you can be really confident that just because it's cold and wet outside, it hasn't caused any damage to your knee and it's not making your knee any worse. So I think the main thing for me is just to remove the fear from that statement and not to worry about it too much, because you know, from the literature we know that there's no significant damage or long-term effects of cold and wet weather on joints, even though it might make them feel a little bit more painful. But it's certainly nothing to worry about.
Perfect.
We've got a couple more. Well, there's a couple more we could just run through before the end if people have still got time. So the next one is footwear related to knee pain? And that is a nice tricky question. So there are instances where it may be a cause, but again, I would go back to what I said before regarding the squatting question and talk about progressiveness. So if you've worn a particular pair of trainers or pair of shoes for a long period of time and then you change to a new pair and that increases your knee pain, it can be because you've changed slightly the way that you're walking and your body may not be used to it. So the key for that is, you know, if you can either go back to the old footwear, that's fine, but if you need to wear the new footwear for any particular reason or you just like the pair of trainers that you've bought, the body is pretty good at adapting. So if you continue to do so, you continue with all the strengthening, you continue with everything we talked about in that pyramid, you know, that you should, you know, that pain will ease out. Again, I wouldn't worry too much about the footwear that you're wearing, and if you know you've been wearing trainers and shoes your whole life, as I have, it's very unlikely that all of a sudden that's going to be really detrimental to your knee. So it's just about adaptation over time and progressively introducing things.
Yeah. We've got another question in here as well. Is rowing machine okay to use? What I would say to that is don't limit yourself on any exercise or activities. Don't be afraid to do different exercises. I don't know if people may have told or anything. So basically, it goes back to what we said in terms of modification of movement. So in rowing, so when we're rowing, obviously we have to bend the knee quite a lot to get into that close range of the part of the exercise. If it gets a bit sore at the very end range, just modify it. Just change it so you're not rowing right into that deep kind of flexed range. You can row into that more comfortable range. Just modify the size of the movements. If you find the knee pain gets more painful after a certain period of time, change it, reduce the intensity of it, reduce the speed of it, whatever you need to do to modify it. So if rowing's an exercise that you enjoy to do, you are not going to do any damage to the knee by rowing. All you need to do is modify or change it to what's a tolerable load for you. So I say yes, you're absolutely fine to use rowing once you modify it to what you feel comfortable doing.
Yeah, and just to add on to that, Paul's exactly right. It's about modifying the exercise so it's okay for you. So if your knee is absolutely fine now and you're not in any pain whatsoever, then yeah, row away. That is absolutely fine and do it how you like. If you have knee pain already and you know what kind of knee pain it is, so if it's meniscal pain, for example, sometimes when you bend your knee beyond 90 degrees, that can put a little bit more pressure on the meniscus, on that cushion, on that pad. So if you're rowing and you know you have a meniscus injury, then I would do exactly what Paul said. Just keep on rowing, but just modify the depth to which you go into, so you're not taking your knees beyond 90 degrees, and you're going to be much better there. So similarly with cycling or static bike in the gym, if you're finding that at the top of the range of movement that your knee is a little bit sore, you can just raise the seat. If you raise the seat a little bit on the bike or on the static bike in the gym, you'll find that you don't have to bend your knee up as far and you don't get as much pain. So it's about modifying tasks, not stopping things altogether because they might be a little bit aggravating. It's all about, have fun, have a play around with your exercises, but, keep on doing it is the main message.
Yeah.
And we've had one more come in, and I think we can squeeze it in.
Yeah, let's go for it. Go on.
Can knee pain have an effect on other parts of the body, bad ankles or hamstrings? I said, over time, if you're constantly limping or your knee is constantly bent slightly because you have a bad knee, then that will affect the hamstrings or the ankles, definitely, which is why maintaining that range of movement with stretches, maintaining that strength with hamstring exercises and quad exercises is really important. So if your knee is got good range of movement and you're functioning normally, then the effect it has may not be as large. So it's mainly to do with if there's a significant change in either how you walk or how you hold your knee. So if it's slightly in flexion. And it's an interesting point regarding rehab as well. So what they found with patellofemoral pain in particular is that it's sometimes to do with a lack of strength at the hip as well as the knee. And exercises targeted at patellofemoral pain should include strengthening of the hip, so some of those clamshells that were on the exercise program, some of those double leg hip bridges that were on the program, they need to be included in that program to help offload the stress that goes through that knee. So yes, we as physios we would call it the kinetic chain. So what's above the joint and what's below the joint. And when we're doing rehab, we think about what's above and what's below and whether it needs strengthening. And similarly to your question, the things up and down the kinetic chain can also be affected by a specific body part. And that's why it's great to see a physio so they can give you some good advice on that. But again, bottom rung of that pyramid, exercise, load management is key.
Perfect. Well, we're going to finish at that, so hopefully that answered all your questions. Really hope that you found it informative and that'll help you in terms of your managed knee pain. Again, if you have access, get into a physio. If you have knee pain, to get more advice and advice on the exercise as well. I'm going to finish it off is that we're going to send out just some survey. So we'll send out a survey. If you can answer the survey, really appreciate it. Just give us some feedback, positive or constructive feedback, obviously, that we can take on board to continue to improve the service. So we'll have that survey sent out, the link to it, maybe in a couple of days. Very quick survey. It'll only take a minute. On my part, I want to thank everybody for attending, and we will have our next quarterly promotion in around February time, and we'll send everybody all the details closer to that time. All right. Cheers, guys. We're off.